Thank you very much. I don't know what to say after Jonathan, so it's a big shoes. And first thing, I want to thank you, Vada, Natalie, Odette, Ossi, who is not here, Leon, Christina, and Mariana, who are just the team I deal with, but also Jonathan, because this happened with the first connection between Jonathan, Natalie, and they contacted me 3 years ago and said, "Do you want to join?" And I didn't know where I was putting my finger. Because progressively I met with family, but this was a sort of connection through Zoom. And Zoom is a bit neutral, so you can control your emotion. But over the last 2 days, it has been just full of emotion because this family is becoming a real family. And I have to tell you, I'm just overwhelmed with emotion. And I thank you, families, also for your gratitude. And the word that I heard over the last few days have been absolutely wonderful. So really an amazing experience. A challenging experience because you have just to be quick when you receive a call for consultation. You have to put everything, your brain, your guts, and say, so there is a child behind. So I need just to do everything I can just to help this child, just to win the battle. And not only to win the battle, but as Jonathan said, to win with dignity and with also as a much or as few side effects as possible. And we are aware that we cannot cure every child. So I have had the privilege just really in 2000 to be appointed in Toronto to build a program. And I will not talk about my life like Jonathan, but this was the dream of my life because the people say, what can we do to make this program the best of the world? And I have to say today, the program is certainly one of the best in the world. And this has been a dream throughout the last 22 years. With a happy end, because I decided to step down 1 year ago and say, now I want to spend more time with low and middle income country where I do a lot of activities. But I left the spot to a very close friend who gave me a lot of trouble because one day in 2003 he came for training from Israel. He came for 1 year of training. And after 1 year I said, I don't want to leave. So I went to the chief of the hospital and said, okay, this guy is really good. Can he stay? And there was a contract by which he was not allowed to stay. But I think I was French, French, they protest and they are just hard to deal with. And finally, there was legal action against the Hospital for Sick Children because of that, but we won the battle and Uri stayed, and Uri is now the chief of pediatric neurology in Toronto. He's my boss because the minute I left, he said, okay, I'll recruit you back. So I'm still working with Uri. So I'm going just to talk today about a few things that already Jonathan mentioned, but I'm more just somebody who like to deal with, visual and a picture is worth 1,000 words. So I want to show you what it means, what are in the progress and what it means for us. So Jonathan mentioned that when he started neurology, he saw the development of the first CT scan. And I remember my boss, who is still alive, and I met her last week. She's 87 now. And she was one of the founding members of the International Society of Pediatric Oncology. And she told me that they had no CT scan when she started. So how can you diagnose a brain tumor with no CT scan? And we always say we are on the shoulder of giants, and these are the giants. They are unbelievable, the work that they have done, and they paved the way to our own career. So it has been really something that we learn also from our experience. So just to show you what it means. So this was a CT scan. And on the CT scan, you see there is something here. But this is an MRI scan, and you see that there is more white stuff around, which is called edema. So that's the swelling which is around. It's not the tumor. And you can see the tumor. And with this, the surgeon have been able just to be more focused and just to not only able to identify where is the tumor, but to remove it with less damage to the surrounding brain. And the progress in neurosurgery have been tremendous over the years. And so this is another example where this patient had a CT scan, and very often Dr. Finney and myself, we have been involved in legal cases where the CT scan here was reported as normal because nobody could figure out that this was a tumor. But when you do an MRI scan, you can see like the nose in the face, that there is something wrong here. So that's really how the MRI scan has impacted on the diagnosis of brain tumor. And that's why it's so important to have modern tools. And there have been further advances because we can look at this and say, this looks low grade or this looks high grade now with new techniques of MRI scan. So very important, and the radiology is a critical part of the diagnosis. The problem is when a child has a headache or something which doesn't look normal, so how can you have the MRI scan? And often the delay in the diagnosis is due to the complexity of the journey from the symptom to the MRI scan, and sometimes the lack of awareness of many people, including some doctors who do not have the knowledge. So we try to develop campaigns to increase awareness about brain tumor among the community, in particular doctors, GP, but also teachers. And there have been campaigns in the UK which have been successful. I just finished to work with my colleagues in Jordan, where we finished a similar campaign throughout Jordan. The second thing is neurosurgery. And so this is a picture from 1960. So in an operating theater, and they are operating a brain. And you can see something that Dr. Finney mentioned, the microscope. It's not here. The people were looking here and just trying to remove the tumor. So that's how neurosurgery was. And in neurosurgery, there is a giant who was working 100 years ago called Arik. He was working in Boston. And he wrote several papers. He was really the founder of pediatric neurosurgery for brain tumor. And he was describing this operation. And it's unbelievable how really he was precise about what he was seeing. But you say, I cannot believe that they were able to remove a tumor. Of course, the mortality rate and the morbidity rate was very important. So what has changed in the 60s? So this is now a room or some tools that we have, or the neurosurgeons have in the theater. So they have a microscope, of course, and the microscope is very good. So they can see just a millimeter of the tumor or brain with the microscope. They have also something called ultrasound. So they take the ultrasound and they can see where is the tumor and where is the brain around during the surgery. There is something which is very, very interesting called neuro navigation unit, which matches what we see on CT scan and MRI scan with the head of, the device that is removing the tumor. So you may say, so we don't need a surgeon anymore with this. It's not exactly true. They have something called plaques, and this is, in the past we used to put films like this on the wall. The plaques is the picture on the computer, and you have seen plaques certainly if you have been to a hospital. But this has been a major advance, and not that old. It was in the 90s, in the 1990s, where the plaques was developed. And during surgery, the people, they monitor the activity. So if they remove something, let's say in the spine, they want to see if the patient is going to walk after the surgery. It's not only about removing the tumor. It's also that the patient wakes up and can walk. So they monitor the signal at the top of the feet, and they say, okay, there is something wrong when I touch here. Stop. And that's a special person in the room who is monitoring this and telling the surgeon, okay, you are doing something wrong. So this is a teamwork in the operating room. And when you go in the operating room, there's not only one surgeon and one anesthetist. It's just like a souk. There are 20 people in the room, but everybody has a role. And it's very expensive, of course. And as Dr. Finlay mentioned, we have now the intraoperative MRI scan, which comes in the room, and you can scan the patient and say, okay, you need to remove more or not. So this has been a phenomenal change in the management of patients. The other change, I am trying to be very, very simple here, is the radiation treatment. Radiation is X-ray. So you can just bombard somebody with X-ray, it's going to work. You will treat the cancer with X-ray. But the question is how much damage you do. And in fact, I was talking about Cushing. Cushing in the 1930s, 40s, he realized that surgery was not enough. And at that time, there was a lady who was working in France called Marie Curie, and she developed, the concept of radiation treatment. So Harvey Cushing, he took the example of Marie Curie and said, I'm going to use the same technique. And at that time, Cushing was doing an autopsy on every single patient who was dying from a tumor. And he realized that some of these patients that he treated for medulloblastoma eventually died, but when he was doing the autopsy, there was no tumor. It was because their brainstem or their brain was burned by the radiation treatment. So that's how we discover the efficacy, but also the limits of the radiation treatment. So one of the aims was to balance this efficacy and the toxicity. And this is now why you hear about conformal radiation, which is this technique. And you can see when we draw, where do the X-ray go? When it's red, it's the maximum dose of X-ray. When it's blue, it's still a low dose of X-ray, but a dose that can cause some damage. And you can see with this conformal radiation, and when you look at the heart, for example, a patient who gets radiation to the spine is going to receive a significant amount of radiation to the heart. So which means that perhaps 20 or 30 years after, he may develop some heart problem. And so we need to be aware of this because cure has a cost, but we need just to decrease this cost in the long term. And so there have been new techniques using still the same technique of radiation called photon, where instead of giving one field here, people were coming from the angle and say we can minimize the exposure to the heart or to the lung. So people have made tremendous progress, but certainly the best one is proton, which is a different technique using a different device, which is much more expensive. You don't feel ashamed, there is no proton in Israel, there is no proton in Canada. So it's just the same. We are in the same.
They have now in Adassa.
Yeah.
No, in Ichilov they're building.
No,
but in Adassa they will.
Okay, so you are lucky we don't have. Yeah. So, but you can see that there is no blue here. It's just all this is limited to the place that you want to give the radiation treatment. It doesn't mean that the efficacy is better. Okay? Proton doesn't improve the survival or the cure rate. It decreases the side effect. Okay? That's only about trying to think long term. The other thing that was important, this is a picture from Edith Patterson in 1953. And so in the first time where she described the treatment of medulloblastoma, which is a malignant brain tumor, about which Dr. Finlay was talking about, where you need to give radiation to the brain and the spine. And Edith Patterson, she said, the problem is just the kids, they don't stay still. So she put this system with 2 planks. The child was squeezed between the 2, and she was giving the radiation that way. So not very comfortable, and she was telling the child who is semi-comatose is a better candidate than the child who is lively and just full of life after surgery. So it was really the beginning. So now we put the child to sleep, and this has been a phenomenal progress. A progress, but you have to realize that it's not easy to get a special anesthetist for this, and many institutions struggle with this. And access to radiation needs also a team of people working together just to make things happen quickly. But certainly one of the big and massive improvement and progress has been in the diagnosis. I didn't start with the diagnosis because the diagnosis influenced the treatment. So this is a microscope, but the microscope was invented in 1600. So it's around this. It's 400 years old. So, and this has not improved. There have been some improvement, but when you look at the technique, it's just pretty much the same. So it can tell you whether the cell is a normal cell and a cancer cell. But then when it comes after, you may have some staining that tells you that the cell is that cell or this other cell, but it's essentially based on the skill of one person. And you have some pathologists who are absolutely phenomenal, but you can realize that this depends on the skill of somebody. And in that way, when you work with somebody, and in Toronto, I work with Cynthia Hawking, and she's absolutely wonderful. And I can just leave, she's excellent. But in some places, you cannot say the same. And the question is, how can you just level this? And in fact, the progress didn't try to address this question, but there has been progress that has, in fact, answered this question. And one is to use specific technique, and in particular the sequencing machine. So what is sequencing? I took the example of a mini, okay? When you see this mini, you say, okay, it's in a mini, but you don't see what's inside. Whether it's, of course, if you listen, you will hear that one has an electric engine and the other one has a gas engine. But when you look at the car here, you cannot guess. And this is the same when we look at sequencing. Sequencing is going to look inside and tell you what is wrong in the cell. And with this, it's going to give you first an answer of what is the diagnosis. And it's a slide that may make you busy, but it's how, not exactly sequencing, it's called methylation here, will cluster tumor in one place or another one. So it will minimize the risk of having a wrong diagnosis. So you put the tumor into, a machine, and it gives you the answer. It tells you that this is MBWNT, for example, on the top, and not another one. And that's how now people, particularly when the diagnosis is not easy, they ask the question and they try to answer what is the exact diagnosis for this child. So a very important tool, but it doesn't really give you the answer of how to treat it. And how to treat it is a sequencing one. So it will give you an idea of what are the alterations. And there is a list of different jargon, ATT, ARID, and etc., which are the genes that are analyzed. And we have thousands of genes. So sequencing is looking at each genes. So we can reduce the number of genes and do a sort of mini sequencing, or look at every single gene and do a whole genome sequencing. And look at the genes that are turned on or turned off. And how does this affect the treatment? It affects the treatment is because we have cancer cell, which is on the wall, and some drugs. And there is not a drug for every single gene, but the number of drugs is increasing. And it's like a plug. So if you use the right drug for the right gene alteration, you will switch off the tumor. But if you use the wrong plug, it's not going to work. So that's how we call personalized or targeted treatment. It's just all about, I make it simple, but it's relatively simple. The people who are doing the great job are the people who are developing the drugs. And so this is something which is very complex and very sophisticated. But this is what or where we go now. It doesn't mean that there is no role anymore for chemotherapy. Chemotherapy is still a big part of the treatment. But we see a transition, and when Dr. Finlay said the last 10 years have been the most exciting years in his life, and for me it's the same, because we see this transition, and we hope that with this approach, progressively, the dream is that we will abandon the need for aggressive treatment that may cause long-term side effects. Now it's not a futuristic way to think at this, but it's happening today already. We are at a time we may see even a change in the role of neurosurgery. Why? It's because this sequencing, we can do it on some fluid. And so, for example, if we take some CSF, which is the fluid around the spine, we can do the same test. And I know some kids who have been treated without any touching their brain. So when they go back to school after their treatment, the other kids, they say, "Where were you?" So I say, "I had a brain tumor." They say, "You are a liar because you have no scar on your brain." So it's difficult to explain, but a number of these kids are now treated without any surgery, and we can see in the future that this may happen more and more because of this progress in the technique. So at the end, what we dream of is just to have a diagnosis without, an aggressive surgery and a specific treatment for every child. It's happening in some diseases. It's still a dream, but it happened in some very bad diseases, and we are working hard on this just to make it happen. I always said in the past that when I would be 50, I would do skydiving. I did it. It was a fantastic experience. I said, I'm going to retire when I see an improvement in the care of DIPG. And so that's why I decided to step down from one thing, but to continue to work, because I want to see this improvement. So I finish here. I'm happy to answer any questions. I thank you very much again.